This is Dr. John Bennett broadcasting from beautiful Miami Beach. Today we have another in the minimally invasive spine and brain conference led by Ashish Tandon of India. And I'll let him take over the show. Welcome, Ashish.
Yeah, thank you. Thank you, John. Welcome, friends. I'm again very happy to host this another session on minimally invasive forum program on brain and spine. Today, we have focused mainly on brain with Professor Charles Teo and Professor Tripathi talking on different aspects. We would be covering on trigeminal neuralgias in the future as well, because there's a wide spectrum. Today, we would be starting off with Professor Teo's lecture. He's talking on keyhole approaches for mesial region of the temporal lobe. As you are all aware, Professor Teo is a world authority on keyhole approaches to brain. He has deep interest not only in practicing keyhole surgery, but he is one of the biggest proponents of keyhole neurosurgery. He has practically lifted this science and pushed. So it was Pernesky who really started the whole movement, but all credit to Professor Charles Teo to making it sort of a household name as far as keyhole surgery is concerned, and especially in brain. I must tell you that I learned a lot. I was with him back in Sydney, and I learned a lot as far as keyhole brain is concerned. And then I used all those dictums for spine as well. So it's been a great journey. So thank you, sir, for helping us out, and we are all super excited to have your lecture. Over to Professor Teo.
Well, thank you for that lovely introduction, Ashish, and welcome to all the participants and to some familiar faces, Manjul, John Bennett, of course, who is the brains behind all of this. John, congratulations and well done. Thank you. Now just going to share my screen. Hopefully it will work. Okay, so if I could just have someone assure me that they can see my screen.
Yes, perfect.
Yes, we can.
So my topic today is keyhole approaches to the mesial temporal area. It is an incredibly challenging area. I find it incredibly challenging because usually to get to it, you either have to go through some pretty eloquent brain or go under some pretty eloquent brain. And hence the reason why so many skull-based surgeons and innovative surgeons have thought about many different other ways of getting to this area without damaging brain on the way. I'd like to divide it up, if you don't mind, into mesial temporal lobe, in other words, the intra-axial portion, and the cavernous sinus, the extra-axial portion of this very difficult to access area. The mesial temporal lobe, of course, comprises many different structures, and I guess all I'm trying to say with this slide is that they're very important in terms of eloquence, memory, personality, vision, etc., etc. I think when you are considering surgery in this area, the mesial temporal area, you should put into your equation for determining the approach whether the lesion is anterior temporal or posterior temporal, whether the lesion is intra or extra-axial, whether you're going through the dominant temporal lobe or the non-dominant, and when they have a pre-existing preoperative visual field defect or not. And because vision is just so at risk in this area, how important is driving to this person's vocation or this person's quality of life? There are some facts that you will glean from the literature, and they're pretty disturbing, really. The facts are that any transcortical approach in this area will run the risk of causing a visual field defect. Now, we all know about the anatomy of Meyer's loop. We all know that it sort of sometimes drapes the frontal part or the anterior border of the temporal pole and the temporal horn. But the anatomy does vary, so that sometimes it extends well in front of the temporal horn and other times it drapes it, as in subpendimal. Any transcortical approach on the dominant side runs the risk of a language problem. And if you look at the literature, this can be as high as 18% or as low as 5%. And again, the literature is absolutely full of articles talking about the danger of temporal lobe retraction and the consequences of retracting too hard on the temporal lobe. If we look at extra-axial tumors, let's talk about all the different keyhole approaches. Now, why keyhole? Because by definition, this is deep to the surface. It's a mesial temporal area. So there's virtually no indication whatsoever to have or approach this through a large craniotomy. So they can all be approached through a minimally invasive keyhole craniotomy because, of course, these lesions are by definition deep to the surface. So we're talking this area right here. This is a small glioma within the, I guess, the anterior mesial temporal area. And an eyebrow approach gives you beautiful access to this area and complete resection of that lesion because of its mesial location. Here's another one. Again, complete resection through an eyebrow. And the tips and tricks here are simply, you've got to try and position the patient so the temporal lobe falls out of the middle cranial fossa. So it's a lot of lateral or contralateral rotation to encourage that temporal lobe to fall out of the middle cranial fossa. If the lesion in the mesial temporal area extends laterally, then unfortunately, and I'm talking, any more lateral than the temporal pole of the the temporal horn of the lateral ventricle, then that makes it very difficult to access these lesions from an eyebrow incision. And to get more access, of course, if you widely split the Sylvian fissure, it will give you more lateral access. Here's one lesion that I didn't quite appreciate. You can see that if the lesion was confined to this area right here, then an eyebrow approach is a beautiful approach. But once it extends out too laterally, it is actually difficult to reach out laterally. And you can see that I didn't get a complete resection of this lesion because of the impedance created by the MCA branches and MCA trunk. So just remember that this eyebrow approach is for very mesial temporal lobe lesions, not if it extends beyond the temporal horn of the lateral ventricle. Just please remember your anatomy of this very, very eloquent area. This is a diagram showing Meyer's loop and how it varies in its anterior extent. Sometimes it's quite posterior, never going anterior to the temporal horn, and other times it extends up to almost up to a centimeter in front of the temporal horn. So any sort of approach runs the risk of causing a visual field defect. I use QuickTome, a product made by Omniscient, of which I'm a consultant. But it's a beautiful product that does not only show you the obvious tracks and parcellations that are at risk, but also the not so obvious ones like the higher order networks. This is me using QuickTome to assess the white matter tracks around a mesial temporal lesion for visual. And you can see that you can really look very nicely, magnify closely, add parcellations, and really ascertain the entire visual network. This is me looking at language, same sort of thing. Now remember, of course, language is no longer the simple Broca's, Wernicke's, arcuate fasciculus. That was our old-fashioned sort of view of speech, but language incorporates many parcellations or many grey matter areas of the temporal pole as well as the inferior frontal gyrus. So all of these parcellations are all part of language on the left side. And if we incorporate this information into our preoperative planning, then of course the hope is that we're not going to damage too much eloquent brain on the way into these lesions. If they've got a preoperative left superior quadrantenopia, as this patient did, then of course the risk is less because they've already got a visual field defect, and you can do a more direct approach, or I guess what I'm saying, a more posterior approach, because you don't have to worry about those fibers that are already destroyed. This is a Cavenoma, same sort of principle. This patient already had a pre-existing visual field defect, so we did a transcortical approach to this for a complete resection. And you can see that the tumor has been completely removed, but clearly I would have damaged Meyer's loop, but thankfully the patient already had a problem. So my tips and tricks for intra-axial mesial temporal lesions, either through a transcortical approach or through an eyebrow approach, are: any transcortical approach should be as antero-inferior as possible to avoid Meyer's loop and speech parcellations on the dominant side. Transcortical is probably as safe as subtemporal. I know that's a broad statement, but you know, subtemporal really does create a lot of retraction and damage to the temporal lobe, and you could probably even minimize some of that damage by doing a transcortical approach. Transsylvian should be reserved for those patients who have a preoperative visual field defect or in whom the lesion has split the fissure already. Keyhole techniques are absolutely applicable to these lesions because corticectomies, because of course it's deep to the surface, and the corticectomy less than a centimetre will reduce damage to this very eloquent brain. Here's another example of a mesial lesion that that extends too lateral for an eyebrow. So because it extends too lateral, because it comes into the sylvian fissure, and you can see that it breaches the sylvian fissure, we're going to do a transsylvian approach to this lesion because we won't have to go through any eloquent brain whatsoever. So extensive mesial temporal, but extending into the sylvian fissure. So all we need to do is split the sylvian fissure and we should get direct access without damaging any normal brain. Time won't permit me to show you the video, but suffice to say that we split the fissure widely through a mini Tereonal, got into the tumor, and never had to breach any sort of normal brain. At the end of the operation, you can see that we went all the way mesial because this is the free edge of the tent. This is the third nerve going in the back of the cavernous sinus. So it's a pretty nice demonstration of a transsylvian approach to this lesion with complete resection, showing all the structures medial to the temporal lobe. And again, pre-op, we came in through the sylvian fissure. We wanted to take out this entire area here, all this area behind the middle cerebral artery trunk. And you can see we've managed to get a complete resection and with a good outcome. Here's a patient that had no preoperative visual field defects, so we're not going to go transcortical in this one. We're going to go transsylvian, mini Tereonal craniotomy. And again, you can see a complete resection. Let's talk about the posterior mesial temporal area. I really like the SCIT approach, the supracerebellar infratentorial approach, because again, you're not coming through lateral structures, you're just coming from underneath. It's excellent when there's significant intracranial hypertension because you get good CSF egress through this approach, and raised ICP in the supratentorial compartment doesn't stop you from getting a good corridor. The major advantage, of course, is preserving all those white matter tracts that coat or are very closely adherent to the lateral border of these lesions. So here's a nice small one, good one to try to start off with. It is in the posterior temporal area, and we're going to go infratentorial supracerebellar to the back of the temporal lobe for a complete resection, and again, a complete resection. That's the approach. I used to do the patient in the lateral decubitus. I now do them supine and with the head turned, but it's a small straight incision, wide opening of the tent to get the mesial temporal lobe. Is a larger lesion, but despite being quite large, it had not caused a visual field defect. So any sort of lateral approach would have given this patient a visual field defect. He happened to be an airline pilot, had to preserve his vision. And so we did, again, a skid approach, infratentorial, supracerebellar, wide opening of the tent to get access to this very mesial posterior temporal lesion, a complete excision, and a good outcome. It's another one. This is a transcortical approach to the posterior mesial temporal lobe. So it's a dangerous approach because you're going through probably a lot of either IFOF or optic radiation. So you've got to be very, very careful. Again, how do I do these? It's from a very low approach, very, very low approach to try and get underneath the optic fibers and underneath IFOF. And you can see we've done a very good resection, complete resection through this posterolateral transcortical approach. And if you really want to extend that further, if it's a big lesion, you can do basically an entire lateral approach. It's the transcortical Equatorial Approach, Leo's mesial temporal lobe, well written up by Mitch Berger's group out of UCSF, showing that if you go nice and low, all the way along the inferior temporal gyrus, you can expose these entire lesions and get good resections without causing visual field. Now, the approaches for extra-axial tumors are a little bit different. I like the Tereonal approach. I don't have to go through it. We've been through it before in previous tutorials. Position the patient with the malar uppermost, just like a Tereonal, but this is going to be a mini Tereonal. And again, I would strongly suggest you try some nice little lesions like this meningioma as your first sort of attempt at a mini Tereonal. Malar uppermost, the incision is much more anterior than you've been taught. Why is that? Because there is a safe area where you can make the incision. That safe area is called the 50-yard line. It's the halfway mark between the tragus and the outer canthus, and the branches of the frontal nerve, facial nerve, the frontalis branches, in most cases run in front of that 50-yard line. So that means having the incision back here, like we were taught by our forefathers, is wrong. In fact, you can have the incision right here, as long as you're behind the danger zone. And that incision is usually at the anterior border of the hair-bearing area. So that allows us to do a mini Tereonal craniotomy as opposed to the standard Tereonal craniotomy. Muscle splitting incision, finding the Tereon, dissecting the way down there, and then reopposing the muscle on the way out, double-breasted closure. And again, a very cosmetically pleasing incision because it's usually just behind the hairline. What are the indications for the Tereonal approach? Well, we all know how versatile it is. It's basically skull-based lesions of both the middle cranial fossa and anterior cranial fossa, temporal pole, outer sphenoid wing, cavernous sinus lesions, aneurysms of the circle of Willis. You know, all those pathologies that can be approached through the Tereonal incision can be approached through the mini Tereonal incision. I often get told, how do I choose between an eyebrow and a mini Tereonal, given that they subserve, you know, this, almost the same area? Well, remember the 2-point rule, the long axis rule. That's one way of determining. But another way of determining is to know the limitations of the eyebrow. The eyebrow is very good for the upper half of the lateral wall of the cavernous sinus. Any lesion that extends into the middle cranial fossa below the halfway point along the lateral border of the cavernous sinus is difficult to access through an eyebrow. And that's how I do it. So again, no middle cranial fossa extension, clearly an eyebrow. No anterior cranial fossa extension, in other words, all in the middle cranial fossa, clearly a mini Tereonal. Remember, the skull base morphology changes as you get older. In children, the angle is extremely acute. In adults, it's not so acute, which means that an eyebrow anterior cranial fossa approach does give you very good access into the middle cranial fossa in an adult, gives you poor access in a child. And here's some examples of the limitations. This is mostly anterior cranial fossa with extension to, it's almost to the floor of the middle cranial fossa. But again, if you look at the morphology of the skull base, it's a very blunt angle there, not a sharp angle. So I should be able to reach down the middle cranial fossa through an eyebrow, and I did. You can see the eyebrow incision here, but after a few weeks, you don't even see that. Here's a lesion, again, straddles the sphenoid wing, half in the anterior cranial fossa, half in the middle cranial fossa. I would suggest in this case, you use the approach you are most comfortable with. Given that I've done over 1,000 eyebrows, I'm very comfortable with an eyebrow, especially if it doesn't go all the way down to the middle cranial fossa floor. This one again, I did through an eyebrow. This is clearly a middle cranial fossa tumor. There's no anterior fossa extension, but look at this. It doesn't go anywhere below the halfway mark along the cavernous sinus wall. So this is a case you can absolutely do through an eyebrow incision because you can get down to that level. And here's the sagittal on that very case. Look how blunt the angle is. It's not a sharp angle. It's nice and blunt. So obviously I could reach down and get that out. Look at this one, however. This is where I was really pushing my luck. I was trying to do this through an eyebrow because it straddles the sphenoid wing. Most of it's actually in the anterior cranial fossa. But remember what I told you. If it hits the floor of the middle cranial fossa, it makes it very difficult to get a complete excision. And as you can see, I did an inadequate excision and left tumor behind the middle cranial fossa floor. I really should have done this through a mini Tereonal. Another case, and we won't have to go through the video. The Tereonal does cause some temporalis wasting. The mini Tereonal causes much less, but it still does cause a little bit of muscle wasting because by definition, you're stripping quite a bit of muscle, as opposed to the eyebrow incision, which causes virtually no temporalis wasting. So again, that is one of the things that will help you make your decision between eyebrow and mini Tereonal. Okay, let's talk about the subtemporal approach. It can be a craniotomy or craniectomy. It was first described for trigeminal neuralgia. It was popularized by Charles Drake as an approach. This is amazing. If you look at the literature, he did 1,700 aneurysms through a subtemporal approach. That, of course, those figures will never be duplicated ever in the history of mankind. It does give you excellent and rapid access to the lateral cerebral peduncle, high basilar tip aneurysm and aneurysms of the PCA. The tent may be cut to offer better access to the upper pons, and the extended subtemporal approach incorporates drilling features apex. Trouble is, it does require retraction of the temporal lobe, and remember all the complications that are specific to the subtemporal approach. If you go really low along the skull base, and that's what you have to do, you have to go low, then in some cases you're going to enter the mastoid air cells. So please be cognizant of that and seal them up before you open the dura. Remember, the fourth nerve enters the back of the cavernous sinus, but can enter the free edge of the tent in varying different levels. So you've got to identify it, see where it enters the tent so that you don't damage it when you're doing a transtentorial subtemporal approach. And remember these contusions. I like to think that I'm a pretty gentle surgeon. I don't use fixed subcutaneous retractors. I really encourage CSF release by opening all the cisterns, but I've been unpleasantly surprised that several of my patients have suffered from non-symptomatic, but still significant temporal lobe contusions. They're much more common than you realize. How do you position the patient? The whole positioning is all about getting the temporal lobe to fall away from the skull base. So it's a very extensive lateral extension. It's a straight incision, straight down the bone, nothing fancy, no flaps. Try not to use retractors, of course, on the temporal lobe. And if you don't think you're going to be able to open CSF early in the case, then you will have to consider a lumbar drain. That's the approach. You're going to cut the tent. a straight incision. Watch the fourth, and remember the fourth can vary in its penetration of the tentorial edge. You don't have to make these big incisions. These are cases that had been done by someone else, couldn't take the tumor out, came and saw me, and you can see that my incision was significantly smaller than theirs, because really you don't need to expose all this temporal frontal lobe because it's a subtemporal approach. So really it's only a small incision in front of the ear. Remember how dangerous it is to retract the temporal lobe, and sometimes, like I said, it's safer to go through the temporal lobe, especially if these lesions extend significant superior extension. So you can see that if I did subtemporal here, there's virtually no way I could get all the way up here without damaging the temporal lobe. So my approach instead is a transcortical, transventricular, transchoroidal approach, which gives you beautiful access to the equator of this lesion, so you can go up and down and get a complete resection, as we show here. Transcortical, transventricular, transchoroidal, complete resection, and minimal damage of the brain, the temporal lobe. Again, small incision. This patient had a biopsy through this incision, had a complete resection through this one. And remember the 2-point rule. This is a patient that had been done poorly by someone else, poor resection. And why? Because they just didn't remember the 2-point rule and follow the long axis or the trajectory of this lesion. Again, how I did this: transcortical, transventricular, transchoroidal, so that you can look up and down and get a complete resection. This is, again, the biopsy at another hospital. This is how we did it: small incision, because that's all you need to do this transcortical approach. This is the video of a pontine cavenoma, subtemporal because there's brain behind it, and just to show that you can reach down to the bottom of the pons. You can reach down to the bottom of the pons using endoscopic guidance and endoscopic assisted surgery. Another cavenoma, again, the long axis, subtemporal. And I might show you a little bit of this video if you don't mind. So we're on the patient's, what side are we on? On the patient's right side. So we're now under the temporal lobe. Here's the free edge of the tent. We're opening the cisterns to let out CSF. We're going to look for the fourth, and we can see the fourth already. There it is, the fourth. So once you know where it is, you can preserve it. We're opening the membrane of Liliquist now. We're going to open the tent, so we're going to coagulate the tent first. This tent can bleed like stink because it's got venous lakes in it. So a generous coagulation, opening of the tent, and then generous burning of it. Again, not opening it until you identify where 4 is. And here's just an example of those big venous lakes. Look at this big venous lake in the tent. It's common. Don't panic. It happens all the time. Just coagulate, coagulate, coagulate. And now we've opened the tent. Here's the petrous apex. Here's the lateral cerebral peduncle. And now we're looking for the discoloration of the cavenoma. And once the cavenoma is out, we put the endoscope in just to make sure. Again, petrous apex, tent widely open, fourth nerve preserved, back of the dorsum sella, back of the dorsum sella, back of the clivus, and putting the endoscope in to make sure we've got a complete resection of that cavenoma. And you can see a complete resection, small incision, subtemporal approach. What about the subtemporal approach for extra-axial lesions? If it involves the lateral wall of cavernous sinus or intracavernous, if there's no supraclinoid extension, and if it involves the lower half of the lateral wall, then sure, this is a subtemporal approach. Perfect example, small trigeminal schwannoma. What are we doing here? We're going to go subtemporal, not transcortical for a complete resection. Small incision again, right in front of the tragus. Now the trigeminal neuralgia, trigeminal schwannoma. Again, small incision, subtemporal approach, underneath the temporal lobe, virtually no retraction. and generous use of the endoscope to ensure a complete excision of this schwannoma. Beautiful view with the endoscope showing all the fascicles and branches of the trigeminal nerve in Meckel's cave. You can do big ones as well through a subtemporal approach. Why? Because again, using the endoscope, you can reach back into the posterior fossa and achieve a complete excision of a lesion like that with a good outcome. Third nerve after the operation, 6 months, no third nerve palsy. Here's another one, subtemporal approach, beware temporal lobe contusions. I thought I did a great case here. Thankfully, this hematoma was asymptomatic, but what we're going to do is a subtemporal approach to take out this lesion, and look what I did post-op. Okay, great resection of the lesion, but a hematoma in the temporal lobe. Thankfully asymptomatic, but this could have been quite disastrous if it had affected some of the speech areas. So, you know, you can be as careful as you like, you can be as cognizant if you like, but I'm telling you, it's actually very easy and very common to damage the temporal lobe with a subtemporal approach. And because of those very reasons, Myers loop, language on the dominant hemisphere, temporal lobe contusions, CSF leak through open mastoid air cells, damage to the fourth nerve through sectioning of the tent, seizures, etc., etc. All the problems associated with getting to the mesial temporal area, in other words, retraction or transgression of the temporal lobe, can be obviated if we come from a medial approach. And hence our endonasal colleagues and myself, we've been very, very strong in trying to find different ways through the nose and through the sinuses to get to this area. So let me quickly tell you about the transmaxillary transcortical approach to the middle cranial fossa for small lesions of the temporal pole. And then I'm going to just introduce you to transorbital approaches, even though I don't have any personal experience. You've got to know your anatomy well, and your anatomy will tell you that once you get to the back of the maxillary sinus and go through the pterygopalatine fossa, intertemporal fossa, you've got to know the anatomy. You've got to know that you've got V2, you've got IMAX, you've got fat pads, you've got the infraorbital nerve. You've got to know your anatomy because that's quite an eloquent area that you're going through to get to the temporal pole. I usually sacrifice IMAX. I know it's hard to do that, but they usually have no consequences. So I sacrifice IMAX, I retract a V2 to get to this area here. So this was on the dominant side. I didn't want to retract the dominant temporal lobe. It was very anterior. And you can see that this can be readily approached through a transmaxillary endonasal operation. So so there's two ways to get into maxillary sinus. You can go through the nose and just take away the medial wall after you medialize the lateral turbinates, or you can actually do a Caldwell-Luke type approach through the anterior wall of maxillary sinus through the gum. So I don't like that approach because I get numb teeth sometimes. I'd much rather do the endonasal approach. But either way, you get into the maxillary sinus, go to the back of the maxillary sinus, open that up, get into all those structures and the pterygopalatine fossa, and that'll give you beautiful access to the temporal pole. Here's the operation. Again, I'm sure I'm running out of time, but essentially, what side are we on? Oops, sorry, let me just quickly, so we're on the left side. So we're on the left side, it means that this is the middle turbinate. This is the concha. So we're going to medialize the medial turbinate. We're going to open the piriform fossa. We're going to open the entire medial wall of the maxillary sinus. Once we get into the maxillary sinus with this feeler finder, we'll take away the entire medial wall. To expose the posterior border or the posterior wall of the maxillary sinus. Here it is here now. So the medial wall's gone. This is the left maxillary sinus We're stripping the mucosa. It's very thin bone. We're going to take the bone away. Once we get into this infratemporal fossa, sorry, this pterygopalatine fossa, we're going to see the familiar structures of V2 and IMAX. This is the fat pad. This is IMAX. Okay, so we're going to suck away the fat pad. We're going to put some clips on the IMAX. We're going to sacrifice IMAX, and we're going to retract V2 out of the way to get to the posterior wall of this fossa. In other words, the anterior wall of the middle cranial fossa. So this is now middle cranial fossa. We're going to take off the wall. We're going to open the dura, and when we open the dura, it's going to devascularize this meningioma. It's a beautiful approach, except you do get praxis and sometimes paresis of V2, and that causes numbness of the gums, and patients don't like that. So here we go. Here's the dura, the front part of the middle cranial fossa. We're going to use frameless stereotactic guidance to make sure we're exactly right. We're now using this co-blader to coagulate the dura, and by coagulating the dura, we are devascularizing this meningioma, and you can see meningioma already right here. So it's a very nice approach, very direct, but just a word of warning, you are jeopardizing the integrity of V2, and that can cause numbness of the gums, which patients just don't like. Here's a meningio coming out now, no brain retraction, early devascularization, wide exposure, and easy to plug that up with a dural type substitute, a bit of a fat graft, a bit of glue, and then a nasoseptal flap. Here's a pre-op x-ray showing the tumor right here and right here, post-op showing a complete resection, and again, a good outcome. Look, I haven't done the transorbital approach. I'm terribly sorry, but it is being popularized these days, and it does give you good access to that very same pole area. There's no brain retraction, but it's a very narrow corridor, and you do run some risk, although very low, to the orbital contents. It's a very good cosmetic outcome as well. So here it is in cartoon fashion. Frontal part of the middle cranial fossa, orbit. Here's the bone that you're going to be drilling off, and there's the corridor. It is a limited corridor, but again, it's becoming very, very popular, and not an unreasonable approach to this part of the middle cranial fossa. In other words, the mesial part of the middle cranial fossa, but lateral to the cavernous sinus. There's the sort of lesion you can do. There's the bone you're drilling off. There's temporalis muscle. So thank you very much. If I could just summarize by saying that the mesial temporal area consists of both intra and axial lesions that are very difficult to access because of the eloquence of the brain that's overlying that area. You can sometimes go through that brain with minimal damage by using good preoperative maps to show you where the parcellations of all the networks are, where all the white matter tracts of the networks, and try and avoid them. You can also use the transcortical approach if they've already got a pre-existing problem. But really, if you can help it, try and get to that area through any other approach, eyebrow, through the nose, subtemporal, whatever you can do to try and avoid damaging that brain, which is very eloquent, is very important. So, and remember, keyhole is the rule, because it is deep to the surface, and you really never need to do anything more than a small incision and a small craniotomy. Thank you.
Thank you so much, Charlie. Appreciate your wisdom on the approaches to the mesial temporal area. There's one question from one of the participants, and that is, how often do you use lumbar drain?
I probably only used it 3 times in 30 years. So once every 10 years, I find a case that I just have to use it. You very rarely need a lumbar drain. There are a lot of complications associated with lumbar drainage, not from just you, the insertion of it, the staff, but also the nursing staff. So if you can avoid it, try and avoid it. And in most cases, you can avoid it because you can get early access to some systems, some CSF. Now, sure, sometimes with large tumors, you think to yourself, well, there's no way I'm going to get any CSF egress until the end of the case. And they're the cases where you have to use a lumbar drain, but they're very few and far between.
Okay, thank you so much. Now, I have a few questions that I've written it. Now, what is your take on the lateral supraorbital approach? Because
so the lateral supraorbital approach is, I mean, I know a lot of people use it. I know a lot of people use incisions like through the eyelid, through the outer canthus. Look, each to their own. I understand why they do that. I understand that some people like taking the orbital rim to look higher up. I don't have to do that. All I can say is that I've never had to extend an eyebrow approach through an eyebrow incision because I'm so adept at using the endoscope. Now, if you're not adept at using the endoscope and you can't look up and look down to the fossa, then sure, you're going to have to think of more elaborate ways of getting access. But you know, for me, it's a whole lot easier to use angled visualization and angled instruments, so I don't have to extend my eyebrow incision or extend the frontal craniotomy. So I don't take off the orbital rim. I don't do a lateral excision. I don't extend it laterally. All I do is make my incision in the hair-bearing area and small craniotomy, leaving the orbital rim alone. And sure, if it's a craniopharyngioma, for example, that heads right up into the lateral ventricle or third ventricle, I just use the endoscope to look up. I don't take the orbital rim to look up.
okay.
Excuse me, Ashish, we have a question from Samuel El Morsi, a noted neurosurgery educator from Egypt. Are you there, Sam? Well,
Yeah, his
Sam,
question
are you there?
is,
Well, he asked how to localize precisely small, deep lesions intraoperatively.
which tool is more beneficial?
Yeah.
Yeah.
So it's a good question, you know, because it shows how much experience he's got. He wouldn't ask that question if he hadn't had problems. And you know, anyone who's had a lot of experience with small cavanomas in the mesial temporal area will, you know, if they're honest, I'll tell you they have had trouble. And I'm certainly one of them that have had trouble finding small lesions. There's no secret, Sammy. I guess the secret is that some of those small lesions, you might just have to wait until they get bigger. Now, with the cavanoma that you're worried it might bleed, sure, you know, but there's no secret. They are hard to find. They're absolutely hard to find. And you find it very difficult to poke around and start looking around because you're going to start damaging optic tract, optic fibers, IFOF, et cetera, So I'm sorry, there's no secret. I use frameless stereotactic guidance. I try and I localize the lesion before too much CSF is released and before the brain starts shifting. So I get my pointer, I find the lesion, put the pointer in and out a few times to create a tract, and then I use high magnification microscope to follow my tract to the lesion. And have I ever not found a lesion? Yeah, I can think of two embarrassing cases where I actually didn't find the lesion because it was so small. In retrospect, you know, I actually did want to do those cases. One of them presented with epilepsy. So of course I wanted to do it. And the other one was a cavanoma, and they'd already had one bleed and they didn't want any more. So I identified it was going to be difficult, but I just didn't realize it was going to be that difficult. So I'm sorry, there's no secrets. Frameless stereotactic guidance, try and point to it and create a track to it before there's too much brain shift. And that's the only two secrets I have.
Okay. Thank you so much. What are your thoughts? And I think this we can cover in this part of your lecture, and it's about the tumors in the posterior part of the temporal horn of the ventricles, and your approach through the inferior part of the posterior temporal lobe. So, can you just give your thoughts on that?
Well, unfortunately, we've got more information these days than we had in the olden days. In the olden days, you and I used to think, well, you know, we always stick needles through that part of the brain when we do a shunt insertion. And so I was taught that a lot of the brain there was non-eloquent. So if any sort of posterior temporal lesion had to be accessed, I'd sort of just pretend I was putting a shunt in through a very posterolateral approach. Well, unfortunately, with modern technology, we now know that that so-called non-eloquent brain that we went through is actually quite eloquent. It's got parcellations of these higher order networks that, you know, you and I weren't even privy to before 2016, but we know about them now. We know that the central executive network, the default mode network, VAN, DAN, all have parcellations that could potentially be damaged going through cortex in that area. Firstly. Secondly, again, I was ignorant of IFOF and the importance of IFOF. I can remember one case where I went posterolateral through the cortex and clearly damaged IFOF. The patient was mute and was really hurt by the operation. I had no idea what I had done until I showed Mike Chagru, and Mike goes, "You know, you're an idiot. You went straight through IFOF. That's why the patient did so badly." So with that new information, I think it's now irresponsible to ignore that. And that posterolateral approach to posterior mesial temporal lesions, well, I don't like it, Ashish. I don't like it at all. I would much rather do a skid approach, you know, infratentorial, supracerebellar, wide opening of the tent, so you don't have any sort of hurdle or impediment on the way in, is a much safer approach. In other words, coming inferior, not coming lateral.
Laterally. Okay, fine. This is a little different from the topic, and that's more on the work on connectomics and the website. So I was introduced by one of the personnel from Omniscient Technologies regarding their website and a lot of literature on parcellations and areas. So do you think any of the viewer here or any student can go onto their site and access the information that is available and, you know, sort of take help from there?
Oh, absolutely. Yeah, no, look, I would strongly suggest that all the young trainees that are listening to this go to the Omniscient website. And there's some tutorials, there's some guides, there's pictures of Glasser's atlas. There's examples of tumors that have been taken out much more safely using Omniscient technology. Yeah, no, it's a great resource, just the website alone. You don't have to buy anything, you don't have to pay for anything. If you go to that website, you'll realize that there's a wealth of knowledge out there now about the eloquence of the brain, those parts of the brain that we used to think as being non-eloquent. The right frontal pole, the right temporal pole, the left temporal pole for 5.5 centimeters, the left frontal lobe. Now, all these so-called non-eloquent brain parts of the brain, we now unfortunately know are eloquent. And the reason we used to think that we could get through those areas without causing problems is because we didn't realize we were causing. We never looked for them. You know me, my greatest failing in my entire career is using this as my metric of success. So if I had a patient who could talk and not be hemiparetic and not move, not have any movement problems, I was happy.
Yeah,
I didn't do a deeper dive into their cognitive functions.
Yeah,
I didn't do a deeper dive into their emotion and all those things that can affect quality of life just as much as a hemiparesis, possibly more than a hemiparesis.
True.
So because I didn't do a deep dive into them, because I never documented problems with those higher order networks, I thought that I was doing a pretty good operation. But in fact, what I was doing was damaging parts of the brain that were causing problems with quality of life that I didn't even acknowledge. So gone are those days, Ashish. Gone are the days where we can be ignorant, and gone are the days where this is your metric of success. They can no longer be acceptable. I'm sorry.
Is that omniscient.com, Charlie? Omniscient.com?
Actually, I don't know. Sorry, John.
Okay,
Ashish might know the website, but
Yeah,
anyway,
we're
I'll
trying to
finish it.
put-
What,
yeah,
what
trying to
I
put
was
in the chat.
thinking, yeah, what I was thinking of, John and Charlie, in one of our forums, if somebody from Omniscient Technology can, come and present just for 10-15 minutes on their website, and the amount of material that can be accessed free of cost, that would be a great help to our viewers.
Great.
And that would come into the public domain as well.
Okay.
So if it is possible, then we would like to invite one of their team members who can just expose us to what all the website contains and how we can benefit from it.
Great. Smashing
That's
idea.
a good suggestion. Yeah, it's a good suggestion. Look, any talk now that mentions an approach that breaches normal brain, so any talk that talks about a transcortical, transsulcal, transgyral approach to a lesion or to the, to a tumor has to include the knowledge of, has to include the updated knowledge of the brain.
True.
And in other words, the connectomics, the networks, and their eloquence. I mean, we just have to do that now.
Sure, sure. Okay, Charlie, thank you so much. I don't think so we have any more questions from the viewers. So I would shift my attention to the next topic.
Thank you very much.
Thank you. Thank you so much, sir.
Thanks, Charlie.
Also, maybe, Charlie, you can, one of the other days, you can present on keyhole approaches for MVDs, because that is what we want to take up in the near future. Like we have started with Manjul, with gamma knife for trigeminal, we would want to do other non-invasive and then MIS approaches. So would love to have your views on that as well.
Okay.
Very good.
Thank you, thank you, thank you. So welcome Manjul, welcome aboard, and thanks for accepting this invitation. We are very eager, though we are a little late, but we are extremely eager to know what's going on as far as gamma knife is concerned for trigeminal neuralgias. So to quickly introduce, I can see here Manjul Tripathi, Associate Professor from Department of Neurosurgery and Gamma Knife Radiosurgery, PGI. Manjul is an extremely young and enthusiastic neurosurgeon who publishes a lot and who's very active academically, and he has made all of us, all Indian neurosurgeons and worldwide, proud. So once again, welcome Manjul, and please, the platform is yours.
Thank you, sir, and thank you. My personal thanks to you for telling me an extremely young, because I am seeing my graying hair over there, and I am thankful to Dr. Charlie for setting the tone of my presentation. So it's a keyhole to no hole now, because now I'm going to talk about the stereotactic radiosurgery. So there is not going to be a single incision over the head. Anyway, so thank you to the organizers, especially John and Professor Charlie and Professor Ashish. I'm going to speak on the current status of the stereotactic radiosurgery and its role in the management of the trigeminal neuralgia. These are my disclaimers. So just to take my viewers to the place where we work, it's in the foothills of Himalaya. It's a postgraduate Institute of Medical Education and Research, and I'm a gamma knife radiosurgeon and a microneurosurgeon, so I practice all these microneurosurgery and the gamma knife radiosurgery. It's a public sector hospital, and it takes care of nearly around 80 million patient population of the surrounding areas. Before I do this talk, I would like to just make a clear statement that I do not contest the gold standard treatment status of the microvascular decompression as far as the trigeminal neuralgia is concerned. MVD is the benchmark, I have no doubt in it, and the literature supports my statement. However, it is not always the safest option. It's an invasive treatment, and in my own personal experience of nearly around 110 patients of trigeminal neuralgia treated with MVD so far, I have a couple of complications like a CSF leak, and one patient having a post MVD occipital neuralgia, and a case of facial paresis. So among all options, whatever we have for trigeminal neuralgia management these days, I do not contest the safety and nearly equivalent status of the gamma knife radiosurgery in long term for the pain control. Most of the time, the neurosurgeon is not the primary person to take care of these patients. And these patients primarily go to the ENT surgeon, dentist, neurological colleagues, pain clinics, and then they get referred to the neurosurgeon when the treatment becomes refractory to the medical management. Because of the lesser awareness, there are frequent questions like, does gamma knife really work in this? What are the long-term results? Can it be treated for the recurrent pain? Can it be used for the primary treatment option? Is it really effective in the long-term pain control? Can we use it in the failed cases as well? So this is actually the base on which we are going to work today. The definition of trigeminal neuralgia, what are the cafeteria choices, when to offer SRS among these choices, what are the specific indications, outcomes, and complications, SRS among different options of the treatment, and controversies with the SRS. The diagnosis, the management of the trigeminal neuralgia actually starts with the correct diagnosis. And I am so sorry to say that most of the dentists make the people edentulous in my practice. They do not diagnose it correctly as a trigeminal neuralgia. They take it that it is actually a dental pain. But when the patient is actually do not get any pain relief, then they get referred over. When they fail, the patient is referred to the neurosurgeon. So the gatekeepers sustain a very important role in the management of trigeminal neuralgia. Make the correct diagnosis on the first hand, check and recheck it. Only once you are sure, then go with the protocol-based management. And it is very necessary for us to diagnose it correctly and treat it in a protocol-based manner, because it is one of the most common reasons for the litigation worldwide. Among the causes of the litigation for trigeminal neuralgia, after the surgical complication, in 32.7% cases, it was the failure to diagnose it correctly. And you can see here that the defendants are the dental surgeons and the neurosurgeons. So it's very necessary to safeguard ourselves and to diagnose it correctly in the first step. The definitive diagnosis of trigeminal neuralgia has been updated several times. The key points are unilateral pain lasting for a few seconds to few minutes, arising spontaneously, occurring in paroxysm and triggered by the innocuous mechanical stimuli or the movements. The patient may be completely pain-free in between. Usually the pain occurs in the daytime, and very rarely the patient would tell you that he had a pain in the night and he got up because of the pain. Another important and many times the crucial indicator of the trigeminal neuralgia is that it gives a very good initial response to carbamazepine. But eventually the medical management with carbamazepine, oxcarbamazepine fails over the course of time. Either the patient becomes intolerant to the drug therapy or they start getting complications of the drug therapy. Broadly, it is categorized into the three categories like idiopathic trigeminal neuralgia without any apparent cause, classical when there is a neurovascular conflict, and secondary when you have some skull-based pathology or some other reason like multiple sclerosis. I always start with the medical management because response to the carbamazepine confirms that I am dealing with the trigeminal neuralgia in most of the cases. Nearly 50% patients achieve a satisfactory outcome. And if you just, in the very beginning, you ask the patient to undergo surgery, they are usually reluctant to it. So let them have a medical management. If they just respond to it, nothing better than that. The interesting fact is that there is no definition when to call that this is now a medical failure. So I see people coming in the OPDs for even more than 2 decades with the medical management, with a cocktail of medications and their complications. When some physician offers them a surgical option, they change the physician, the next one adds a new drug, sometimes a new antidepressant. But the common sense says that if the previously managed patient on some 2 medications get uncontrolled with the maximum tolerable dose and is not tolerant to the side effects of those drugs now, I call it as a failure. So when Professor Lars Lexell was perplexed on the issue of the poor results with the conventional neurosurgery for many things, he envisioned gamma knife radiosurgery with a primary indication in the functional neurosurgery. And his motto was early lesioning with the high dose for the functional indications. In 1951, he treated the first patient of trigeminal neuralgia with an orthogonal X-ray tube and a Lexell frame. The target was at the Gasserian ganglion. The patient was pain-free for nearly 18 years, and that was really a pretty impressive result for that duration of time. In 1963, when the carbamazepine was introduced, it took care of most of the patients for a shorter duration of the pain control. Lexell also championed other techniques of the percutaneous glycerol injection. And Lexell lost his interest in the early days for the trigeminal neuralgia. So this is actually the historical perspective. And if you look at first Posterior was done in 1951, then it went into a little sabbatical. But in 1998, Douglas Konzelka published an important article with the multi-institutional study, and he again set the tone for the gamma knife as an effective treatment modality. In 1983, last lecture showed that from these observations, no definite conclusions should be drawn concerning the optimal dose of radiation or the exact mechanism and site of action. So there was a lot of controversy on the target to be chosen, how much drug to be given, how much dose to be given. But now, if you look over the course of years, the trigeminal neuralgia makes nearly 90% market of the functional radiosurgery throughout the world, and it is the FDA approved indication for the management with radiosurgery. So now I can say that it is the second term for gamma knife after 1990s, because now our radiology, we were able to pinpoint the target better, and there were multi-institutional studies doing different protocols over a longer duration of time, and then we could conclude what is good for it now. We can see now that in 2019, this was 82,000 patients throughout the world were treated with gamma knife radiosurgery for the management of trigeminal neuralgia. This is an interesting article. There are different machines with which you can actually treat, like the CyberKnife, Novelis, X-Knife, Gamma Knife, but the maximum literature throughout the world is on the experience with the Gamma Knife. If you just PubMed, you will find more than 750 articles over it. Coming to the technical part of the Gamma Knife radiosurgery, you fix a frame. It's usually a frame-based, even in the times of Icon, because it's a functional indication. And you get the CIS images or Fiesta images, 1 millimeter thin cuts, so that you can see the complete course of the trigeminal nerve, especially the cysternal component of the trigeminal nerve. In Gamma Knife, you have different volumeter sizes. You take the minimum size, that's the 4 millimeter, and with that, you target the cysternal component of the trigeminal nerve, somewhere around 7 millimeter away from the brainstem. And the dose is in the range of 70 to 90 days. What is the best target point? Where is the sweetest spot? Well, there is a conflicting literature over it, and there are different schools of thought over it. You can target either at the root entry zone, you can target in the cysternal component, in the proximal cysternal component, in the distal component, or just where it enters into the Meckel scale. But the best results have been found with the minimum chances of the sensory complications when you target it somewhere around 6 to 7 millimeter away from the root entry zone or the surface from the brainstem. And this area is called the Marseille point, because this was championed by John Regis from the Marseille. There have been different areas where by different you treat. So when you treat with the MVD or with Gamma Knife, it's a cysternal component. When you treat with the
Just be patient. He's having some bandwidth issues.
in this functional radiosurgery, you are doing a nerve modulation, not a nerve destruction.
Okay, Manju, can you hear me? Okay. It'll straighten itself out. It's just the bandwidth, temporary bandwidth.
On which
issue.
slide? Sorry, sir.
Yeah, he'll be okay. It's just, you just have to wait. We'll take a digital coffee break. Ashish, do you have coffee? I do.
Am I audible?
Okay, now that hopefully, yeah, it's okay now.
Oh, I'm really sorry. Did I miss somewhere in between?
Okay, it's kind of rough. The bandwidth's having an issue now, but continue on.
On Professor Ashish. Yeah. Okay. Okay. I'm really sorry. So was this the slide on which I missed?
I don't recall. Does anybody recall? Is that the right slide, Ashish?
Okay, not a problem. So the dose is in the range of 70 to 90 gray. If you give a higher dose, then there are chances of sensory complications over here. While planning, it's very important to safeguard your organs at risk, and those organs at risk are actually the brainstem, cochlea. You should try to minimize the radiation exposure to the brainstem. No part of the brainstem should be exposed to more than 12 gray of the radiation in a single sitting. How does actually gamma knife work in this condition? This is a commonly asked question. In a baboon model, Konjolka targeted the trigeminal nerve and did the microscopic evaluation. The targeted nerve showed the signs of axonal degeneration and loss of the myelin sheath at 80 gray. It causes a selective destruction of the fibers which are implicated in the pain transmission, that is the A delta and the C fibers. It causes the focal gliosis with the reduction of the axonal contact, and it reduces the aphaptic transmission. And it's very interesting to know that the your root entry zone is fanned over a longer length. The central myelin is more radiosensitive in comparison to the peripheral myelin. When you give, you can evaluate the effect on the trigeminal nerve with the DTI. Mosgen-Hodai championed it. The results are very focal because you target with a very small isocenter of the 4 millimeter. So the common question after gamma knife, when should I get the pain relief after gamma knife? Some of the patients tell that they get an immediate relief, while several of them do not get adequate relief even by the end of the 3rd month. Practically, if somebody tells me that they got an immediate pain relief, it might be just a placebo effect. In my clinical experience, patients get a relief somewhere in between the 3 days of the treatment to 3 months after gamma knife. The literature is not sure. When should I say that SRS has failed in a particular case? There is no definite timeline to answer this question. But conventionally, if the patient does not respond even by the end of the 6 months, I consider it as a failure in that particular case. What is the reason that some patients respond early, some patients respond late? The radiation effects on different individuals may take different timeline to act, and this timeline varies from a few days to 12 months, but the average is 1 to 2 months. This review article by Al Otabi, they found the fibrotic lesions and the axonal degeneration after radiosurgery to different extents. If somebody is having an early pain relief, most likely they are going to have a longer term pain relief. What is the long-term pain control prospects with gamma knife radiosurgery? There are various long-term studies. The best studies were by Konjolka and the Regis et al. Regis had 497 patients which he followed for more than 10 years with a primary radiosurgery. So up to 5 years, there is a good pain control. There is a high rate of early pain relief followed by recurrent pain in nearly 50% of the patients by the end of the 5 years. So if you give a lesser dose, the chances of long-term pain control are less. If you give a higher dose, the chances of long-term pain control are better. And the chances of bothersome hypoesthesia are only in around 3 to 6% patients. In the immediate period, patients may have some trigeminal sensory neuropathy in the form of paresthesia or hypoesthesia, but it is bothersome in only around 2 to 3%, and over the course of time, it becomes okay. Marseille group managed 130 patients of classical trigeminal neuralgia, and they followed it up for the 10 years. Nearly 94% responded within 15 days of the treatment. The first graph shows that after 6 months, the graph gets plateau and maximum of the patients respond by that time. The second graph shows that even the complications they have seen, they just plateau after the 6 months and do not worsen. This is Marseille's historical series with the anterior cisternal target called the Marseille point, and this remains the only prospective trial of managing these patients for such a long duration with gamma knife radiosurgery. Many times people ask if there is no neurovascular conflict, would SRS work? Of course, SRS is going to work irrespective of the radiological conflict. Presence of neurovascular conflict is a better indication for microvascular decompression, but it is not a contraindication for gamma knife. So it's going to work irrespective of neurovascular conflict, and it has been proven repeatedly in the literature. By the end of 5 years or 6 years, we again encounter patients who have a recurrence of pain. Now the question arises, should we repeat the radiosurgery or offer them any other alternate treatment modality? If the patient has only responded to SRS earlier, then the second SRS becomes a good option. The pain control with repeat SRS is actually better. There might be slightly higher chances of the sensory complications. Ideally, it should not be repeated before 2 years to avoid any radiation toxicity and the accumulation of the radiation over there. Where should I target if the patient is being treated again? That I'm going to discuss in the next slide. So the systematic review of the literature shows that the prior response to the SRS, sensory trigeminal deficits, and increasing distance between the isocenters of the first and second radiation would increase the chances of the better pain control. There has been a group in Orange County which have treated patients more than 3 times with repeat gamma knife because it responded twice earlier. So it has becoming like an over-the-counter treatment. So the purpose of this study was to know if we should target it somewhere else in the trigeminal nerve, and if you target it nearly around 2 to 3 millimeter away from the primary point of the target, then the chances of pain control are actually better. There is always a question if the patient has earlier been treated with MVD, he remains successfully pain controlled, and later on if the pain recurs, should these patients be treated with gamma knife? So now it becomes a secondary treatment option, and what would be the pain control? So it has been observed that in patients with the previous MVD, the pain control in the early period is lower than in patients who have been treated with the primary gamma knife. But over the course of time, the long-term results are good and are comparable to those of the patients who have been treated just with the gamma knife radiosurgery. Usually the secondary procedure, the gamma knife as the secondary procedure has a lesser pain control in the short term, but in the long term, the pain control is same. Now, there are some unique circumstances. These are not typical or the classical trigeminal neuralgias. What I talked till now was a typical trigeminal neuralgia. Trigeminal neuralgia secondary to the multiple sclerosis, as evidence in the literature review we have found, actually the gamma knife is effective in the short term for this group, for 4 to 6 months. The reason is that the pathophysiology here remains inside the brainstem because of the demyelination, not in the nerve bed. In the long term, these patients are better controlled with the rhizotomy. The trouble is that with gamma knife, the chances of recurrence are high by the end of 2 years to the tune of 61.5%. So it's effective and safe in the short term, but eventually fails in the majority of patients with the multiple sclerosis in the long term. Similarly, another entity is dolichoectatic vessels. I personally have had a hard time with these patients. I treated 3 patients, and all these patients had a good pain control till 6 months, but in the long term after gamma knife, they needed MVD. Compared to the classical trigeminal neuralgia, targeting a patient of dolichoectatic vessels becomes difficult because the nerve gets distorted and most of the times it's atrophic. So this is actually a patient who primarily got treated for the dolichoectatic vessel with the gamma knife radiosurgery. When the pain recurred, I had to treat. It was an uphill task because there was a huge vessels over there to make a sling. And that was the reason I was not able to find the trigeminal nerve anywhere here. So the radiosurgery also failed in this case. There are various groups who claim a good result in these patients, but in my personal experience, I would rather prefer MVD to radiosurgery in patients with the dolichoectatic vessels. If the cause of the trigeminal neuralgia is a secondary skull-based pathology, like a small petrous meningioma or a vestibular schwannoma, it becomes a negative prognostic factor. Most of the time, the pain control is modest in the range of 30 to 60% in different series. The current literature is very heterogeneous and does not answer the 3 essential questions: whether I should target the nerve, whether I should target the tumor, or I should target both of them, and what should be the differential dosing for that. In my personal protocol, I target both the nerve and the tumor, so that the tumor, if it shrinks, it becomes a decompression, mechanical decompression over there, and the patient gets the pain control. And here the pain control up to the 3 or 5 years remains in the range of 30 to 50% only. There are certain controversies which we face in day-to-day radiosurgery practice. Should I stop the drugs before SRS? Infrequently, we get an indication that some drugs may be radioprotected. While it is not so, the use of carbamazepine or gabapentin does not affect the pain output in the long term. However, it has been found that gabapentin may reduce the risk of developing any kind of sensory complication like a hypoesthesia. When should I treat with gamma knife? Should I wait for the patient to become medical refractory? Well, there is no definite timeline in the literature, and this is a very beautiful study done by the Pittsburgh group. And they have told that you should act as early as possible. Because if you get late, the nerve gets demyelinated and gets flattened over the course of time. A longer pain history is associated with the microstructural damage, and there might be a kindling of the secondary sensory neurons. So the patients who have been treated just within 1 year of the onset of their disease, their pain-free period lasts more than 5 years. While if the patient has been suffering from the pain for more than 3 years, he has been on polydrug therapy, the chances of long-term pain control are only up to 10 months or 12 months without any drug. So this pain-free period means BNI 1, you do not need any medication at all. Most of these patients land up in BNI 2 or the BNI 3 when you need some infrequent drugs. Usually the prevailing practice is to do a decompression in younger patient and lesser invasive surgeries in the elderly. Age and sex is actually no bar in the statistical analysis for SRS. Again, the Pittsburgh group showed that the BNI 1 to 3 pain control is achieved in trigeminal sensory neuropathy, and it is comparable across the age groups. This has been found in different series. This is by, again, the Lunsford group, which has found that irrespective of the age, the young and the adult and the older population all have a good pain control with gamma knife. One argument against radiosurgery is the hypoesthesia of variable extent, and this has been reported in 10 to 25% of the patient population for variable duration. However, the bothersome hypoesthesia is only seen in around 3 to 6% of these patients. In my personal experience, most of these patients just respond to 1 month of amitriptyline. If you target a distal point cysternal component, you get an equal pain relief with the lesser chances of the sensory complication, vis-a-vis if you target a proximal part of the trigeminal. This is little technical because we have 8 sectors in gamma knife to target the nerve. If you are not able to safeguard your brainstem or cochlea, you may need to do a beam blocking. If you do a beam blocking, the chances of sensory neuropathy increases little bit. But if you just use all the targets, the chances of sensory complications are very less. Is it difficult to operate in the gamma knife failure cases? No. I have treated nearly 5 or 10 cases who got failed in gamma knife. So the only problem that sometimes you feel is that the arachnoid is thickened over there. Another query which was historically refuted is why not irradiate the ganglion rather than the cysternal component of the nerve if you do not see any neurovascular conflict. The ganglion in appearance looks like a powerhouse too. It was the first target used by the Lars Lexel. Recently, a Colombian group also used the Gasserian ganglion and concluded that the gamma knife on ganglion appears with the short latency period and minor collateral damage. But these results could not be reflected and replicated by other sectors. And I am especially amused by the acknowledgement by Dr. Roman Liskek, who helped in the manuscript, but who does not agree with most of the interpretations and the conclusions of this article. A further controversy which has happened over the course of time is that dose rate, BED, and the outcome. The BED is the biologically effective dose that you deliver to the nerve. So if your machine is new, the source is new, is the effect is going to be better if you treat him early, or you should, and if you treat when the source has got decayed, are the chances of pain control different? The older studies have found that whether the source is new or whether the source is old, it's not going to make any difference over there. But this is one controversy which is nobody has a particular answer. My friend Konstantin Tuleska, you might be aware of him, has championed this, and he's evaluating this problem of the biological equivalent dose. In between the time, various other treatment options have developed, like the glycerol rhizotomy, radiofrequency ablation, balloon decompression, even the high frequency ultrasound. Hysterectomic radiosurgery, where does it fall in this role? We all know that there is no panacea for this disease. Even MVD fails. In today's audience too, there might be many people who practice different techniques for this disorder. Every procedure has its own set of complications and benefits. But as far as the safety is concerned, with the equitable result, there is no comparison of gamma knife. It provides an equal pain control with minimal sensory complication, and there is hardly any chance of corneal hypoesthesia, dry eye syndrome. The only rider is that some patients may need to take drugs for a longer duration of time, even after gamma knife radiosurgery. As far as the long-term pain control is concerned, there is no comparison of MVD. This review presents that 84% patients over the course of 5 years were pain-free after MVD compared to 66% after gamma knife. But gamma knife has a benefit of you can repeat it easily. There are multiple treatment options. If you compare various ablative procedures, the best long-term pain control is seen with RFL, but it also comes with the maximum complications. In its comparison chart, you will find that gamma knife comes with the safest outcome and comparable long-term control of the pain. There is no corneal numbness, no keratitis with gamma knife radiosurgery. In view of the unparalleled safety, radiosurgery remains the most attractive option to the patients and the referring physicians. And in the list of the complications, you can notice that except for fifth nerve hypoesthesia, there is no complication in gamma knife, and that makes it the most popular treatment option among the cafeteria choices. And this is a very recently published study in which they try to evaluate the incidence of the repeat procedures and the healthcare utilization following surgery, radiosurgery, and percutaneous procedure in the elderly patients with the trigeminal neuralgia. And they found that the percutaneous procedures followed by the radiosurgery was the most common procedure used in the majority of elderly patients. But if you compare the need for the reoperation, the minimum chances of the reoperation were with MVD, followed by radiosurgery, but the percutaneous procedure had the highest need for the redo surgeries. The complications may happen with the non-isocentric. It has been mentioned in some cases of the cyber knife because there was a radiation exposure to the brainstem and the ORS. This may happen as no other modality achieves as precise radiation and sharp dose fallout as the gamma knife. When I'm talking about the LINAC radiosurgery, they do not pinpoint any particular area of the trigeminal nerve. They expose the full length, full systemic component of the trigeminal nerve. And that is called the Flickinger effect. If you expose the full length of the trigeminal nerve, your chances of sensory complications are much more. So here you can see that 6-degree cyberknife radiosurgery was done, and there was the temporal lobe edema over here. In this Novalis-based group, Sales et al. Found that the Pons enhancement near the res was seen in some of those patients, and it had a risk of the sensory complications. One or two reports have showed that there might be superior cerebral artery sclerosis or atherosclerosis after gamma knife radiosurgery. In my personal experience so far, I've been safe in that way. So to summarize, what's my strategy now? I follow with the Marseille protocol with a 7 to 8 millimeter anterior to the brainstem, 90 gray at 100% isodose. I try to keep the brainstem away from the 12 gray line. If sparing the brainstem does not become possible, I reduce the dose up to 80 gray, or I change the gamma angle or use the plugin, but I avoid them as far as I can. These are some excellent literature review and practice recommendations by the International Stereotactic Radiosurgery Society, which takes care of all the kind of the stereotactic procedures. So they have found that the single fraction radiosurgery is better than the hypofractionation. The previous surgery is a negative predictor for the pain control, but this does not contraindicate SRS. A neurovascular conflict is not a negative predictor for SRS. The minimum effective dose is 70 gray. Do not increase the length of the treated nerve. So that's the difference where the gamma knife comes in a better position in comparison to the other LINAC machine. They found that an anterior target has a lower hypoesthesia compared to the posterior target. So you should be away from the brainstem. And LINAC and GKR result in the higher bothersome hypoesthesia rate. So the sensory complications are higher with the LINAC-based machines. We need to personalize the trigeminal neuralgia radiosurgery for each and every patient, because every patient's anatomy is different. Some might be having a conflict, some might not have a conflict, some might be having a dolichoectasia. There is no golden spot, a short or a definite sweet spot. You need to adapt to that particular anatomy. And you should describe all the pros and cons of every treatment option. The patient selection is paramount in it. I do not give the treatment to the patient. Once the patient comes with a trigeminal neuralgia, I ask the patient, I explain all the treatment options he has, and let the patient buy the treatment over there. And it's very necessary to maintain an objective record. And I find that the BNI, the Barrow Neurological Institute rating, is the best record to maintain the sensory and the pain-free record over the long term. Once again, it's the patient who takes the risk, not the surgeon. MVD is best. There is no doubt about it. Yes, it is. But is it safest in your hands? Very we also mentioned the complication profile. Well, the patient should know your own complication profile, not of Peter Chavita. So that's the word. That's why the patients are moving towards the more safer option these days. So once again, it's we offer to the patients who are not in the pain crisis phase. If the patient is not able to eat, he is on the Lyle's tube for his feeding, I do not offer gamma knife. I ask them to undergo MVD. But if the patient is an okay pain control, then I definitely offer gamma knife reduced surgery to them. Gamma knife might be the destination or a part of their pain journey. We may actually fail in 5% patients. I accept it. Patient may need additional procedures, and there is no harm in accepting limitation, but it remains the safest option among all the treatment options. A functional radiosurgery, whenever my residents come over there, so they found that for the trigeminal neuralgia, they see the different treatment options. And at that time, it looks as exciting as the teenage sex. And the people who are seasoned neurosurgeons, they find that how can a radiation can treat a pain? So they come out in a phase of the midlife crisis. So I just show them that you need to talk to your patient properly, choose your patient wisely, and then you should offer this treatment to them. And it gives a beautiful long-term and short-term pain control. With this, I would end my talk over here. And thank you very much for this opportunity.
Thank you, Manjul. Well, it was quite elaborate. You covered almost every nook and corner of gamma knife for trigeminal neuralgia, and we are extremely thankful to you. Now, there are a few questions. The first and foremost that almost all of your viewers would be having this is, how do you choose, apart from patient choice, gamma knife being the first treatment of choice, in which selected group you say that, look, you should, if you ask my opinion, you are a candidate for gamma knife?
Sir, if the patient is having a typical trigeminal neuralgia of less than 5 years of the duration, and he's well controlled on the drugs of nearly around 400 to 600 milligram of the carbamazepine, I offer them gamma knife as the first treatment choice. But if the patient is on polydrug therapy, taking nearly 1200, 1600, and is having more than 5 years of the pain history, on the MRI, I am able to see that there is some indentation of the nerve is distorted. In those patients, I do not give gamma knife. If it is a shorter duration, a good amount, 400, 600 milligram, and patient is in the BNI 3 or 4, I offer them gamma knife as the first choice. If it is BNI 5, polydrug therapy, I offer them MVD.
Okay. Now, what is your take on role of gamma knife in post-RF patients, post-balloon compression, or post-glycerol?
Sir, in those patients, whenever gamma knife as a dictum is used as a secondary treatment, the chances of pain control are slightly less in comparison to the primary radiosurgery. So in my own experience, which actually I echo with the literature, the chances of 3-year pain control as a secondary radiosurgery are only around up to 60%. 60% means patients would be BNI 1 to 3 grade. BNI 1 is that you do not need any drug at all for your pain control, and that is achieved in nearly 20% patients. Rest of the patients would need some other drug, but it would be definitely at a lesser dose what they used to take before radiosurgery. So if the patient had been usually at 800 or 1200 milligram of the carbamazepine, the dose reduces to 400 milligram, but still they need some drug for their complete pain relief.
Okay.
I do not claim that every patient becomes a complete pain-free without medication. That doesn't happen. That happens only in 20% patients.
Okay. Now, what you haven't covered in your discussion is the role of gamma knife in, say, residual petroclivals or residual epidermoids, residual meningiomas, residual acoustics. So what is your, if we could get just a gist of how you use gamma knife in this subset? That is question number 1. And what is the current literature as far as MS is concerned?
Well, actually, sir, I included both of them. Probably the slides got missed. If I can share it again, in between the slides were missing, so I'll share it with you again. So that's a unique situation. Is it visible now, sir? My screen?
Yeah,
Yes,
it is.
yes.
Okay. So multiple sclerosis, actually, the Indian population, we hardly see any patient with multiple sclerosis related trigeminal neuralgia. So far, I have treated only 3.
Okay.
That's usually a white population disease. They have in Canada and in some Scandinavian countries, they have a lot of multiple sclerosis. Multiple sclerosis, the pathophysiology is entirely different from the typical trigeminal neuralgia because it's a demyelination inside the brainstem, probably there near the root entry zone and further away in the pons. In those cases, gamma knife has been used at the same target, at the cysternal component of the trigeminal nerve. This is the most exhaustive literature by Konstantin Goleska, where they evaluated the literature on the gamma knife radiosurgery in the management of the multiple sclerosis related trigeminal neuralgia. In these patients, they have found that nearly for 1 year, the pain control is in the range of 50 to 60%, but after that, the pain recurs very soon. And the repeat radiosurgery also does not help much in these patients. So these patients are better treated with rhizotomy because the chances of recurrence are very high when you treat a multiple sclerosis related trigeminal neuralgia. This is a particular clinical entity where the pain control, I do not find more than 1 year we get a good pain control. The pain recurs in these patients. It is safe and effective when you treat it on a short-term basis. Initial pain control is better with a low rate of numbness, but after 1 year, the pain recurs, and then the repeat radiosurgery may be tried, but again, the pain would. So this is not the preferred patient subgroup in which I would advocate gamma knife radiosurgery. I would rather advocate a microsurgical rhizotomy under neuromonitoring. So that's about multiple sclerosis. Coming to secondary trigeminal neuralgia, when you have some skull-based pathology like a small petrous meningioma, a small trigeminal schwannoma, epidermoid. In those cases, it is because of the mechanical compression by that skull-based pathology, which is causing the nerve irritation and destruction. If it is a very small, the literature shows 30 to 60% of the pain control over the course of 3 to 4 years. And there are controversies over it. In classical trigeminal neuralgia, you are targeting the nerve. In skull-based pathology, where you do not have a trigeminal neuralgia, you just target that particular tumor. So if the trigeminal neuralgia is secondary to that benign or malignant pathology, what should you do? So there are different schools of thoughts. Some people just target the nerve, leave the tumor behind. Some people target the tumor and wait for that to shrink so that the nerve get decompressed. And there are some groups which target both. So I am in the third group. I target the nerve so that the patient can get an early pain control before the effect of radiation on tumor appears. But again, in this group, the pain control is 30 to 60% over the course of 3 to 4 years. And then the pain may recur. The chances of pain recurrence are higher than a classical trigeminal neuralgia here.
Okay. Well, I think this was just, I'm sorry.
Yeah, we have one question. Excuse me, Ashish. We have one question from a prominent neurosurgeon from Mumbai, a frequent visitor to this site. Harshad, can you ask your question, please?
Hi, John.
Hello.
Hello, Ashish.
Great.
Yeah, hi, sir. Welcome, sir.
Thank you. Dr. Munjal has given a very wide, elaborate presentation on a gamma knife for trigeminal neuralgia, and you also covered many things. My question was that whenever a patient comes to us with a severe pain, failure of medications, and if we advise the gamma knife to the patient and we give SRS, how long does it take to reduce the pain immediately, or it takes some time, or how long it takes? What do you say to your patients?
Sir, there is no dictum for it, but in most of the patients, the pain relief starts within 72 hours. It does not happen immediately. And the pain relief the graph of the pain control takes nearly around 3 months for the complete effect to appear. Most of the patients who get a pain relief by the 3 months, that becomes plateaued at that one, and it continues for a long duration of time. There's a delayed action in some patients, and if by the end of 6 months the patient doesn't get a pain relief, I consider it as a failure in that particular patient.
Sir, I would like to further extend that you can very easily say that this form of treatment would take the longest time to initiate pain relief, and it generally never is never significant before 2 weeks, I would say. So it is basically, the patient should be well aware that if you're receiving gamma knife, you need to be very patient 2 weeks upfront, and only after that you need to be, because these patients, they have been going to various centers, they are well aware of the options. And so in most of the situations, they have been told that the relief would be instantaneous, whether it is MVD, whether it is non-invasive other approaches, or even for that matter, if the medication is effective, except in gamma knife, wherein the patient has to have patience. So this is a very important caveat, which all of our patients who we are subjecting to. Though I feel, Manjul, most of the patients that are being referred, not direct recruitment, those who are being referred are mostly who have failed either MVDs or RFs or meds, who finally reach gamma knife. That is one subset. And the second subset is where the patients are well aware that, this form of therapy exists, and the patient refuses MVD and discusses with the surgeon, and then this patient reaches you.
Yes, we have some
the primary physician in my case.
I'm sorry?
Yeah.
Go ahead.
The primary physician, So most of the patients are actually referred by the neurologist or the dental surgeons, because the patient first lands up to them. And they start on the medical management. They continue with the medical management for a couple of years, actually, because in most of the patients, the carbamazepine is effective. Once they start getting the cerebellar symptomatology, and the drug once hits 800 milligram, patient starts getting intolerant to the drug. He gets drowsy, his social life, his functional quality of life starts getting affected. And then they start searching the net. And when they search the net, they find the option of the gamma knife. So they come with a clear picture in their mind that we have a treatment option in which there is not going to be any incision, there wouldn't be anything inserted in our head. So they are usually reluctant to take any other kind of a treatment, percutaneous or MVD, whatever you just tell them. If they know about gamma knife, they would just say that, doc, if this get failed, I will take the second option, but first, please let me have the gamma knife. That's the thing which they usually demand these days. Even when you explain to them, they say that this is the safest what I have found. There is nothing going to be on my head, so I'll take this option first.
Okay.
I
think, sorry, John.
Yeah, we have some comments from Mauro Segura, Morelia, Mexico neurosurgeon. Hello, Mauro.
Hi, hello. Thank you, John, and thank you, Professor Tandon and Professor Manjul. You have a lot of experience in trigeminal neuralgia, so I'm agree that it's a controversial point, but not controversial. According to the European paper experience and America and Latin America experience, even for Bombay, Professor Goel, this point is very important. The recovery time after treatment. I mean, how do you say? The time that the patient has to wait to be free of pain is very important. As you know, after microvascular surgery, in my opinion, microsurgical treatment, it's immediately in more than 90%, but much more than 90%. And this is very important. And I'm talking about the classical trigeminal. Talking about the gamma knife in multiple sclerosis, as you showed, Dr. Mayu, it is very risky, as you show, the recurrence of up to 60%. 60% recurrence is more than the half, and you know, you have to wait even 3 months and to do a second dose of gamma knife dose. And of course, the secondary effects, paresthesia, DOMLES, more of those, is very high. You showed many, Juan, maybe Dr. Juan, 40%, something like that. Sorry, 56% of complication or secondary effect. So, in my opinion, it's a third line of treatment. Of course, after, as you show, the medical failure, any medication, carbamazepine or the combination of drugs. So first is very good result with microvascular surgery. Then we prefer radiofrequency. And third, we offer a gamma knife because of the result that you show. And finally, talking about the tumor, benign tumor as meningioma and schwannoma, in that point could be controversial, but if you are a skull-based surgery, it's very easy to reach the skull base. If there is no skull-based surgeon, of course, it's complicated. And the most important that I expect your opinion is to the epidermoid cyst tumor. There is no place for gamma knife because, as you know, it's a very slow, very slow growing tumor, and the compression with this small tumor over the trigeminal nerve root is the cause. So it's very easy to remove from 18 millimeters approach, as we showed maybe 15 years ago. So the very interesting point I would like to know, Professor Majud, is the role of the gamma knife for the refractory cases when the radiosurgery failed in the trigeminal nerve root, surgery, radiofrequency, etc. And then what is the role of the gamma knife for thalamic or thalamic treatment for these refractory cases? Do you have any experience?
Yes, sir. First of all, I would thank you for your comment for that about the skull-based pathologies, because since I am in a unique position, just like you being a hybrid neurosurgeon, a microneurosurgeon and a radiosurgeon, so you can choose your patients wisely. If it is a skull-based pathology, go and excise it, the patient becomes pain-free immediately. And in my initial slides, I told that I do not contest the gold standard status of the microvascular decompression. And I always tell the patients that this is the procedure which is going to make you immediately pain-free without the need of any other drugs. But it's the patient who chooses the treatment option these days. Coming to your second question about the thalamic pain. So sometimes these patients have a deafferentiation and a nociceptive pain, in which case none of the treatment options are actually going to work, your percutaneous procedures or neurectomy or even the MVD. In those cases, yes, thalamotomy has been tried. I personally have not tried over it. People have tried thalamotomy, people have tried a DBS, anterior nucleus of the thalamus stimulation also in those patients, and they have found results of the variable extent. Since what I'm quoting is just from the literature, not from my own experience on the thalamotomy. That remains an option, but that remains an option in the extremely registering cases. Coming to your second question, if the patient has failed on the percutaneous procedures or the MVD, in those cases, gamma knife is tried most of the times, and it gives a mediocre result, not the result like a primary radiosurgery. After primary radiosurgery, nearly 80 to 90% patients become pain-free and remain pain-free for nearly around 3 years. If you treat it as a secondary procedure, getting failed on the primary one, then the chances of pain control gets reduced to nearly around 60% over the 3 years. So the effect is definitely lesser when you use it as a secondary treatment option. And as far as the percutaneous procedures are concerned, as a second option after MVD, my only argument remains about the sensory complications, which are higher with the percutaneous procedures in comparison to the gamma knife. The pain control is nearly the same with gamma knife with lesser sensory complications.
Okay, well, I would rather oppose both of these statements from Mauro and Manjul. First of all, Manjul, as far as RF is concerned, the results of MVD stands on top, then comes RF. And if you look at literature comparing gamma knife versus RF still stands a notch higher than gamma knife. That is what my literature reading has suggested me. So, because the results of gamma knife varies between 60 to 70%, whereas RF would be higher between 70 to 80%, and MVDs would be somewhere between 80 and 90%. And that is why perhaps RF is the most commonest used procedure for trigeminal these days. Anyway, coming to the discussion initiated by Dr. Mauro, though I personally do not do gamma knife, and I am a totally keyhole and MIS surgeon, but the literature, if you look over the last 2 decades, the role of gamma knife for smaller tumors has really increased, be it acoustics, be it meningiomas, and be it petroclival tumors. And so the scenario is changing with time, and more of our patients are going for gamma knife for smaller lesions. Now, like in acoustics, when we started about 2 decades back, and maybe Manjul has the right amount of data, the number of cases undergoing gamma knife for acoustics would have been much lower than now. And also we know that the literature is out regarding the extent of 7th nerve injury that we cause, even with smaller tumors, and hearing deficits that we cause with smaller tumors. So I would again add to some controversy here and would suggest that gamma knife is really gaining popularity as far as these smaller tumors are concerned. What is your take, Manju?
Sir, I thought that what you told is absolutely right. I thought the question of Dr. Mauro was when the ischal pathology is causing a secondary trigeminal neuralgia, because then the ischal pathology gets detected because of the trigeminal neuralgia. If there is only a ischal pathology and that is not causing a trigeminal neuralgia, gamma knife is actually a dictum these days. For a Coos grade 1, Coos grade 2 vestibular schwannomas, gamma knife is the first treatment option, and it usually takes care of more than 98% patients. It takes care. But if it is causing a trigeminal neuralgia, then the patient's concern is actually the pain control rather than the tumor in these patients. So if your indication of the treatment is for the pain control, then a microvascular excision of that offending lesion is a better option. But if the patient is not having any trigeminal neuralgia, then gamma knife should be the treatment option in those patients.
Okay, fine. Okay, so are there any more questions now, or any suggestions, any comments?
Professor Victor, do you want to check in there, Victor?
Yeah.
Victor Perez
Hello,
is there.
how are you?
Perez is there. Welcome, sir. Welcome.
Hello, how are you? Just to congratulate you, because this was a very interesting lecture, and the comparison between several modalities of treatment was very nice. Thank you so much for this amazing lecture. Thank you.
Thank you so much.
Thanks for coming,
Thank you,
Victor.
Thank you, sir.
And we have a panelist from Mongolia, Ashish. I don't know if she can talk. Bayam Batson, can you say hi? Do you have your audio there in Mongolia? She's a neurosurgeon there in Mongolia. And Dr. Hang, how are you today? Do you have any comments you want to say? Perhaps not. Okay, Ashish, back to you.
Okay, so we would be carrying this forward, the path which Manjul has started. We would be taking it forward for trigeminal neuralgias in the coming lectures, wherein we would be focusing on MVDs, keyhole MVDs, RF procedures, and you all are welcome to join us in our next webinar, which would carry trigeminal neuralgia forward. I would like to thank Manjul. I would like to thank Professor Teo once again and all the participants, and John for helping us arrange this. I'm once again extremely passionate about this forum, and I hope we are able to carry it forward. And it would be nice to have more youngsters and seniors coming in and sharing their experience on this platform. Thank you, all of you.
Well, that's great, Ashish.
Thank you so much, sir.
We also put the link to the Omniscient website that you mentioned, and I guess we'll try to have a representative of that country, that company, try to present Ashish. Is that what we want to do also?
Yes, yes, absolutely.
Okay, we hope to bring that. Okay, everybody, we'll see you in about 2 weeks.
Thank you
Thanks,
so
everybody.
much.
Thank you, sir.
Thank you.
Thank you, sir.
Bye-bye.
Bye-bye.